Anemia in pregnancy. Anemia is a common medical disorder in pregnancy and is defined as a hemoglobin level of less than 11 grams per cent. In Singapore, the incidence of anemia in pregnancy is approximately 3 to 10%. In this video, we will be discussing the classifications, causes, effects, clinical presentation, investigations, and management of anemia in pregnancy. During pregnancy, blood volume, cardiac output, plasma volume, and red cell mass increase. As there is a greater increase in blood volume than red cell mass, hemodilution occurs. Hemodilution happens almost entirely in the first and second trimester of the pregnancy, although anemia becomes more significant the third trimester. There is a net increase in requirement of iron as daily absorption of iron from gut increases from 10% to 20% because of increased beta-globulin in pregnancy. Classification of anemia in pregnancy. There are 4 types of anemia in pregnancy. Iron deficiency. 85 to 90% of anemia cases in pregnancy are due to iron deficiency. Megaloblastic anemia, either due to a deficiency in folic acid or vitamin B12. Congenital hemolytic anemia, of which thalassemia the most common variant in the Singaporean population. Acquired hemolytic anemia through infections, drugs, or autoimmune diseases. Causes of anemia in pregnancy. Anemia can be caused by a number of factors which include decreased intake or absorption, poor diet, nausea and vomiting in pregnancy, gut disease or drugs that reduce iron absorption can result in decreased intake of iron in the pregnant woman. Decreased production of red blood cells as a result of bone marrow suppression linked to drugs, chemicals, irradiation or malignancy can also cause anemia. Certain genetic disease like hemoglobinopathies and chronic illnesses may also cause decreased production. Increased destruction or loss of red blood cells from heavy menstruation, analgesics, gastritis or gastric ulcers, piles, antepartum or postpartum hemorrhage, or hemolytic diseases including rhesus incompatibility. Finally, increased demand from repeated and closely spaced pregnancies or multiple pregnancies can also contribute to anemia. Many of these causes are uncommon or rare in pregnancy, and iron deficiency anemia remains the most common cause of anemia in pregnancy. Effect of anemia on mother and fetus. Anemia in pregnancy may cause the following effects on mother and fetus. For the mother, circulatory changes can lead to high-output congestive cardiac failure and make her more prone to infections and puerperal sepsis. Anemia in pregnancy increases the risks of complications from postpartum hemorrhage. For the fetus, there is an increased risk of fetal hypoxia from reduced oxygen carrying capacity in the blood. This may then predispose to intrauterine growth restriction. There is also increased incidence of preterm labor and low birth weight infants, and increased risk of fetal distress in labor. Clinical presentation. Anemia during pregnancy may be either asymptomatic or symptomatic. It is therefore very important to elicit a comprehensive history which includes the following: menstrual history, past and present obstetric history, past medical or surgical history, family history of blood-related disorders, dietary history, drug and toxin exposures. During the physical examination, assess for the patient's general well-being, propped up, stature, nutritional status, pallor, stigmata of nutritional deficiency, example, glossitis, angular stomatitis, koilonychias, Vital signs such as heart rate, blood pressure, and in particular arresting tachycardia. Cardiovascular system such as auscultation of a systolic or flow murmur. Respiratory system such as tachypnea, low transcutaneous oxygen saturation, and in severe cases, lung crepitations from high output cardiac failure. Splenomegaly during early pregnancy. Also examine the abdomen and perineum for operation scars, lax abdomen, number of fetuses, fetal size, malpresentation, fetal movement, fetal heart activity, amount of liquor, hemorrhoids. The investigations should include the following: full blood count, peripheral blood film, red blood cell indices, iron indices. Management and treatment of anemia. The mode of treatment for anemia during pregnancy depends on the severity and underlying causes. Factors such as gestational age and patient's response to and tolerance of side effects should also be considered. The first line of treatment for iron deficiency anemia is oral iron preparations. Parenteral iron preparation is indicated if patient is not responsive to oral treatment. The efficiency of parenteral iron preparation is much better than oral therapy, but it should not be the first line of therapy unless the mother is in advanced pregnancy and close to term. Side effects are rare but include light headaches, flushing, nausea, diarrhea, dyspnea, tachycardia, sweating, and shock. Finally, blood transfusion is indicated in the following situations: antepartum hemorrhage or threatened miscarriage with excessive pervaginal bleeding, hemolytic crisis, severe anemia with impending cardiac failure, megaloblastic anemia. Megaloblastic anemia is due to folic acid deficiency and occurs in about 5% of pregnancies in Singapore. Folic acid is stored largely in the liver and is necessary for nucleic acid synthesis, which increases during pregnancy. The daily requirement of folate for pregnant women is 3 to 6 times higher at 150 to 300 micrograms because of decreased folate absorption in gastrointestinal tract during pregnancy, increased maternal requirements, and fetal requirements. Spontaneous miscarriage, fetal malformations, premature delivery, and placental abruption are some of the suggested effects of megaloblastic anemia. The following tests may be conducted to investigate the presence of megaloblastic anemia. Proper diet and small amounts of supplemental folic acid with iron given routinely is necessary for prevention. Thalassemia in pregnancy. Normal hemoglobin is made up of 2 alpha and 2 beta globins. Thalassemia is a genetic defect in which there is a partial or complete suppression of either the alpha or beta globulin chain, which results in reduced hemoglobin context in the red blood cells. There are 2 main types of thalassemia: alpha and beta thalassemia, which can be further broken down as follows. The figure here shows how alpha thalassemia may be passed down to the children. This is how beta thalassemia can be passed down. Different forms of thalassemia can be diagnosed with Hb electrophoresis at pH 8.6. To confirm the exact inheritance of certain thalassemia conditions, such as alpha thalassemia, genotyping studies of the pregnant woman and her partner may be required. Treatment for thalassemia includes folic acid, vitamin C supplements, and blood transfusion if severe. The partner should be screened to determine if he is a carrier, and if so, the couple should be counseled for prenatal screening and diagnosis. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.